Now, here's the really kind of mind blowing numbers. So, in euploid transfer number 4 and number 5, they found that there were live birth rates of 40% and 53%, respectively, culminating in a cumulative live birth rate, meaning the chance of having a live birth after doing 5 euploid embryo transfers as being 98.1%.
Therefore, concluded that actually implantation failure maybe doesn't really exist. And that when there are three embryos that have failed, if you can correct for all the other factors that you know affect implantation, proceeding with just another transfer the same way might actually be the best next step.
Welcome to My Fertility Podcast, Superhumans, the show that brings you expert insights, personal stories, and the latest in fertility care all in one place.
Whether you're starting your fertility journey, navigating challenges, or just exploring your options, we're here to empower you with knowledge, support, and hope.
Join us as we dive deep into topics that matter most, from IVF and fertility treatments to mental health and wellness.
I'm Dr. Mavis Garcia.
And I'm Dr. Wise. We're two of the fertility specialists at Markham Fertility Centre in Markham, Ontario, Canada. Think of us as your sisters in all things fertility. Let's demystify the world of fertility together.
Well, here we are again on Tuesday. And today, my goodness, we are tackling one of the most frustrating and emotionally difficult topics in reproductive medicine, and that is recurrent implantation failure.
So buckle up, strap in, because this is going to be a really dense, but we hope very informative set of episodes. We're going to be covering definitions, causes, both known and unknown, the controversies, future directions, and of course, some of the guidelines.
Spoiler alert, we told you this is going to be informative, and that's what we want. But at the end of the day, the reality is there are many unknowns in the world of recurrent implantation failure, and we just don't have many clear answers or conclusions yet in the world of medicine and science. So we, as always, are going to be honest and telling you what we know, what we don't know, and where the gaps are. The important thing to know is that even though there is a huge gap in what we know about recurrent implantation failure, there's still many ways that we can continue to move forward. And as you're going to hear from the data, the vast majority of patients do achieve a successful pregnancy even after experiencing multiple implantation failures.
Yes, that is so important. There is still hope, even if your fertility doctor brings up RIF or recurrent implantation failure. And, frankly, it's worth repeating. The vast majority of patients with RIF do build the families of their dreams, but we recognize it can be a really long and tough road.
Let's get right into it. Let's start by defining what we mean by recurrent implantation failure. And full disclosure, it is not always clear cut.
In fact, some fertility physicians actually argue that RIF doesn't really exist as a separate entity and that it all comes down to the embryo and that specific embryo's potential to become a healthy pregnancy. So there was this really awesome study had a great title, Does Recurrent Implantation Failure Exist? Prevalence and Outcomes of 5 consecutive euploid blastocyst transfers in almost 124,000 patients. And this was published in 2024 by Gill et al. In Fertility and Sterility.
And this study made a lot of waves in the fertility world. The main study question was, what are the clinical pregnancy rates and live birth rates in women who underwent 2 more euploid embryo transfers after they had 3 euploid embryo transfer failure in the absence of any other known factors that affects implantation?
Now, here's the really kind of mind-blowing numbers. So in euploid transfer number 4 and number 5, they found that there were live birth rates of 40% and 53%, respectively, culminating in a cumulative live birth rate, meaning the chance of having a live birth after doing 5 euploid embryo transfers as being 98.1%. And in fact, they saw that where data was available, that the live birth rate for transfer of euploid number 4 was actually really similar to the live birth rate of euploid transfer number 1.
Therefore, concluded that actually implantation failure maybe doesn't really exist. And that when there are 3 embryos that have failed, if you can correct for all the other factors that you know affect implantation, proceeding with just another transfer the same way might actually be the best next step.
This study is so interesting, but really sounds like a matter of perspective because, there is still that 2% who aren't getting pregnant, who aren't having those successful live births. And I can't help but wonder, what do they do?
Yeah, in that 2%, it can feel like the end of the world. Like everybody else is getting pregnant except for you, even though you have invested tremendous amount of time and money and resources into these embryos. And let's be real, most people don't have 5 euploid embryo transfers that they can fail to get to that 98% pregnancy rate. Sometimes people have one, some people have two, some people have three. And it can feel like if you're transferring your first or your second and you only have one euploid embryo left, it can really feel like the end of the world and that something needs to be done differently to achieve that success.
What I do think that we can take away from this study, though, is that lots of people can get pregnant after a diagnosis of recurrent implantation failure, and that probably true recurrent implantation failure is fairly rare in the fertility patient community.
Ultimately, back to the definition, there is no universally accepted definition of recurrent implantation failure. Most commonly, we define implantation failure as the inability to achieve a pregnancy after the transfer of multiple good quality embryos. Now, what does multiple good quality embryos mean? Typically, we're talking about at least 3 or more euploid embryo transfers or 4 or more good quality embryos that are not genetically tested.
And so some definitions of RIF will include age limits, like the age of the egg provider, for instance. They might include qualifying statements about the genetic status of the embryo, euploid or not. And some will also look at the number of transfer cycles, not just the number of embryos as well. Basically, there's really a lack of a standardized definition, which severely complicates both research and clinical management because you can have a group of studies that are all looking at RIF or recurrent implantation failure, but if each one defines it differently, then you can't really compare study to study. It's like comparing apples and oranges. And so this is the base, I guess, of all the challenges or complications of studying RIF, of thinking about and of managing RIF.
And to make matters more complicated, there is not only the lack of standard definition on what is recurrent implantation failure, but also there is lack of standard definition as to what is a clinical pregnancy. But is often defined as ultrasound evidence of an intrauterine sac. But we know that whenever there is a positive pregnancy test, that is implantation. Implantation has started, even if it didn't get to the point of an ultrasound evidence of an intrauterine gestational sac. So there is a lot of overlap between recurrent implantation failure and recurrent pregnancy failure. They are related and they're actually on the same spectrum. We did talk about recurrent pregnancy loss in episodes 51 and 56. So go back and have a listen.
Also, while I was doing research for this episode, what I thought was interesting is that the term itself has actually become controversial now. And some experts are moving away from recurrent implantation failure and they're now calling it repeated implantation failure or simply repeated unsuccessful transfers. Regardless of terminology, it represents a significant clinical challenge. And we know, as we've said, the emotional toll on patients can be huge. And frankly, the clinical approach can feel really murky. Generally speaking, we're going to talk about embryo factors. We're going to talk about endometrial factors. And I think of this as, let's say, the microenvironment and the more broad immunologic blood clotting factors. And in my mind, I think of this as the macro environment.
Before we get into the causes of recurrent implantation failure, let's take a minute and talk about what has to go right for implantation to succeed.
Implantation is this super complex interplay between a healthy, receptive, or in my mind, I always say sticky endometrium, a developmentally competent embryo, meaning an embryo that has the potential to develop into a healthy pregnancy. So, ideally, a euploid blastocyst. And of course, this perfectly beautifully synchronized immune and hormonal and blood clotting environment. And so a lot of textbooks will talk about this synchronized dialogue between maternal, like the uterine tissues, and the embryonic tissues.
Exactly. Timing is key. It's like beautiful symphony, an orchestra between all the different pieces. Implantation normally occurs about 6 to 10 days after ovulation, and the endometrium has to be ready, has to be receptive during this magic window of implantation. And it's a fairly narrow time frame. We talked about this in episode 11 when Dr. Shan talked about the endometrium and the role of the endometrium in implantation.
The process of implantation, which Dr. Chan touched on in that episode, involves apposition of the blastocyst and the endometrium. So, this is the two things coming close together. Then, adhesion. So, they actually have to stick together, which is mediated by these fancy cell adhesion molecules. And there's a whole bunch of them called integrins and selectins and mucins. And then, actual invasion of the trophoblast, which is that outer part of the embryo, into the endometrial cells, which is facilitated by even more different kinds of cells, including cytokines, growth factors, and matrix metalloproteinases.
It's almost a miracle that we're all here, right? There's so many molecular signals, integrins, cytokines, and many more. This isn't just about anatomy, it is molecular choreography. And in the context of recurrent implantation failure, the effects can occur at any one of these stages.
All right, so let us start tackling some of the potential causes of recurrent implantation failure. Let's be clear here. We're going to break down these causes in general terms. We are not going to be going through a full review of the literature for all potential causes because, frankly, we would be recording here for weeks. And I'm also not really sure how useful that would be to you as the patient. We're going to talk about causes more generally and then spend more time talking about what we can actually do and the evidence for that. First, we're going to talk about embryo-related causes. The single most common reason for a failed implantation in general is chromosomal abnormalities.
Now, as we know, aneuploidy increases with maternal age, and even morphologically perfect embryos can be genetically abnormal. And that's why pre-implantation genetic testing for aneuploidy can sometimes help in cases of recurrent implantation failure. We talked about pre-implantation genetic testing for aneuploidy at length on episode 30. And as we discussed before, if the contributor of the egg is under age 35 years of age, the rate of aneuploidy, which is abnormal chromosomes of the embryo, is about 30 to 40%. If the contributor of the eggs is between 36 and 40 years, now we're talking about an aneuploidy rate between 50 and 70%. And once you get to be 42 years and older, now we have an aneuploidy rate as high as 80 to 90% per embryos created.
The key message here is that a really large percentage of embryos can be aneuploid, even when they look beautiful, even when they look great. So it's probably not uncommon that someone may have RIF due to aneuploid embryos, especially if they're in their late 30s or early 40s.
Before pre-implantation genetic testing, we can very confidently say that recurrent implantation failure was due to aneuploids because we couldn't test embryos. Now that we have the ability to test embryos, we see euploid embryos fail as well. And we see people that have recurrent implantation failure in the setting of using chromosomally normal embryos. So while PGT can be a very useful tool, it can give us a lot of information, it's definitely not the full picture. And full disclosure, I have had euploid embryo transfers in myself when I was going through my journey that have failed or led to miscarriages. So we know that it happens and we see it in our patients. Now, even with embryos that are chromosomally normal, embryo quality is still really important. Was the embryo a day 5 embryo, or was it a slow grower embryo that only became a blastocyst on day 7? What was the embryo grade? Did it have an A in the trophoblast or a B, or did it have a C in the trophoblast? So, amongst embryos that are chromosomally normal, still the grading of the embryo, the day that the embryo became a blastocyst, and the age of the egg that the embryo came from still has an impact on the implantation rate of these embryos. There is actually emerging research around the mitochondrial function and specific genes and epigenetics of euploid embryos. Unfortunately, at this point, we cannot test for that, but we do know that checking the chromosomes of the embryo is only checking one piece, albeit a really important piece, but it's still only checking one important aspect of the embryo. It's not looking at the entire machinery or the entire reproductive potential of the embryo. So even when euploid embryos fail to implant, even though we know they're chromosomally normal, it can still be due to an embryo factor, just an embryo factor that we're not able to test for.
Also, there's some thought that sperm factors, something like DNA fragmentation, for instance, might play a role, especially in cases with repeated implantation failure despite good embryo morphology. But again, more research is needed on this. If you're interested in hearing more about sperm and about DNA fragmentation testing, you can have a listen to the podcast episodes that we did with Dr. Jarvi, a awesome and fabulous male reproductive specialist. That was episodes 44 and 52 of the podcast.
So now let's talk about endometrial factors, probably the second biggest area to concentrate on in the setting of recurrent implantation failure.
Endometrial causes encompass a lot of things, right from the micro all the way up to the macro. We know endometrial lining thickness matters and can predict chance of successful implantation. This is why we always do at least one ultrasound in an embryo transfer cycle to assess the thickness of the lining. And there was an awesome Canadian paper that showed this beautifully, published in 2022 in Fertility and Sterility. And big shout out to one of my former mentors, Dr. Lou at Mount Sinai, who was one of the lead authors in this paper. The appearance of the endometrium may also play a role, although the evidence here is much more unclear. Sometimes we can see this triple line appearance, sometimes we don't, but there are so many ultrasound technical variables that also affect this.
Speaking of endometrial factors, there's also other things such as intrauterine adhesions, like scar tissue within the uterine cavity can disrupt the endometrial receptivity and can be associated with recurrent implantation failure. You can also have endometrial polyps or submucosal fibroids, and these are structure abnormalities that can interfere with embryo implantation. And this is one of the reasons we always do a sonohistogram prior to planning an embryo transfer cycle.
There can also be a desynchronization of that window of implantation that we talked about. For instance, if the endometrial receptivity or that time of maximal stickiness is not aligned with embryo development, possibly due to some sort of abnormal gene expression or hormonal resistance, that's been also implicated in RIF. Now, endometrial receptivity is super tough to measure. And in episode 11 of this podcast, Dr. Chan talks about this and some of her research looking at this specifically.
Another possible issue is abnormal endometrium microbiota. So, shift in the microbial ecosystem of the endometrium, including things like chronic endometritis, for example, may negatively affect implantation.
Chronic endometritis is basically this persistent inflammation of the endometrial lining and is considered a pretty big risk factor for recurrent implantation failure. And this has been recognized by ESHRE, which is the European Society for Human Reproduction and Embryology, and it has been recently supported by some recent cohort data as well.
So far we've talked about the endometrial lining thickness, possibly the endometrial lining appearance. We've talked about factors inside the uterus like scar tissue or polyps or fibroids, and we've talked about the endometrial microbiota. Another factor related to the endometrium and recurrent implantation failure would be endometrial receptivity. So basically, there are molecular and cellular defects, such as impaired expression of different adhesion molecules, that can lead to recurrent implantation failure because it leads to suboptimal conditions for the blastocyst to attach to the endometrium and start the process of implantation. So, impaired visualization and stromal epithelial communication can lead to recurrent implantation failure.
Basically, there are so many factors that we've talked about, and it really highlights the multifactorial and super complex nature of the endometrial contribution to recurrent implantation failure. There can be structural things, molecular things, immunologic things, microbiologic components. So there's lots of stuff out there, and it's lots of this we're learning about in these basic scientific labs. Scientists where you think about the white coat doing stuff in a petri dish. And hopefully, one day we're going to be able to take what we've learned in these basic science labs and translate it into tests and potential treatment options to really be able to apply this stuff clinically.
Now, let's tackle even a more controversial topic in the world of recurrent implantation failure, and that would be factors related to blood clotting, or what we call thrombophilic factors. Thrombophilia basically talks about different things that can increase somebody's risk of blood clots. This can be congenital, it's something that you're born with, or this can be acquired, which are thrombophilias that you acquire later in life.
For the record, it's important to point out that you can have an increased risk of blood clotting without having had blood clots in the past. And when we're talking about blood clots, we're really talking about blood clots in the leg or blood clots in the lung. So, specifically, something called a deep venous thrombosis or a deep vein thrombosis, or a pulmonary embolism, or a type of stroke, which is a blood clot in one of the blood vessels in the brain. Oftentimes, patients will often ask about blood clots in their menstrual flow, but it's important to point out that blood clots in the menstrual flow are completely different and are not an indicator of blood clotting issues necessarily, and blood clots in the menstrual flow are totally different.
Before we get into more detail, I think I need to say it again. This is extremely controversial. In other words, it's not very clear at all, and we're going to get into the evidence later, that thrombophilias or things that increase your chances of blood clots have any implication in recurrent implantation failure. But it is out there, it's talked about in the Facebook groups and on Instagram. So we want to make sure that we cover it here on the podcast as well. One of the most commonly implicated inherited thrombophilias, which means things that you are born with, would be factor V mutation, the prothrombin gene mutation, the MTHFR mutation, and other ones like plasminogen activation factor, factor A, another mutation of the factor V gene, and beta fibrinogen mutation.
Among some acquired thrombophilias, the presence of antiphospholipid antibodies, which can include anticardiolipin antibodies, lupus anticoagulant, anti-beta 2 glycoprotein 1 antibodies, have also been associated with a higher risk of implantation failure, even in women who don't necessarily have a formal diagnosis of antiphospholipid antibody syndrome. And again, antiphospholipid antibody syndrome is something that we talk about quite a bit in the recurrent pregnancy loss episodes that we've mentioned earlier. Again, just to reiterate what Dr. Garcia has said, the clinical associations, the clinical significance really remains debated. So there have been several systematic reviews, meta-analyses that highlight that while certain thrombophilic factors are more prevalent, meaning it's more likely that a woman who has RIF may have one of these factors, routine screening for these things is not universally recommended because evidence is very inconsistent. And even if you try and treat these things, there's a lack of clear benefit to actually improve the outcomes at the end of the day.
Now, testing might be considered in selected cases, for example, in people where there is a personal or family history of thrombosis or other risk factors for thrombophilias.
All right, so next up, we're going to talk about immune causes or the immune system. I would venture to say that all fertility physicians will agree that the immune system is really important and plays a big role in successful implantation in pregnancy. But we really do not understand the quote unquote nuts and bolts of how everything works. So again, we're left with a lot of theories without necessarily a lot of great evidence or proof.
So theories would be the role of natural killer cells, the role of cytokines and the Th1, Th2 ratios, the roles of HLA mismatches between partners. So those are the theories. But again, there is really limited consensus on how to measure them and how to treat them reliably.
The testing protocols vary so widely. Should you be doing blood tests? Should you be looking at the uterus specifically? Can you look at menstrual blood? Then there's all these treatments out there that are being sold as being targeted towards the immune system, like intralipids, IVIG, steroids, tacrolimus. But these are used often empirically, meaning that we're starting these treatments based on the most likely cause of the condition before we have a definitive diagnosis or test result. So we don't really have that robust data. But for those of you who know us well, we are going to be working on a whole series of episodes specifically looking at the immune system, immune testing, and immune treatment. We do promise that it is coming. So please stay tuned for that.
Yes, you're right. A series of immune protocols episodes is coming up. And speaking of that, I need to go and keep writing. So I think this would be a good time to end this episode. In the next episode on this series of recurrent implantation failure, we're going to be talking about the diagnosis workup and some of the treatment options that we use in the setting of recurrent implantation failure to help you achieve a pregnancy.
And that's a wrap for today, Superhumans.
If you're looking to connect, get social with us. Follow us on YouTube and Instagram at My Fertility Podcast or visit us online at myconfertility.com. And don't forget, follow, subscribe, and share your favorite episode.
Thanks for listening to My Fertility Podcast and for being a vital part of our community. We know you've got this.
We're signing off until next Tuesday.
If you found this episode of My Fertility Podcast helpful, please take a moment to head over to the review section and leave us your thoughts. Your reviews and comments are incredibly valuable to us and help guide future episodes. We also welcome you to direct your questions to info@myfertilitypodcast.com.
My Fertility Podcast is produced by Rabbit Media Inc. in conjunction with Dr. Garcia and Dr. Weiss.
Music from Mixkit, Life is a Dream by Michael Ramir C.
My Fertility Podcast is not intended to replace any type or variation thereof professional medical, health, or legal advice, nor should the content be taken as medical advice. Please contact your primary healthcare professional regarding any medical questions you may have. The information presented in this podcast is based on the knowledge and understanding of the host at the time of recording. Medical knowledge is constantly evolving, and new research may change the understanding of health-related topics. While we strive to provide accurate and up-to-date information, we do not guarantee the completeness, accuracy, or timeliness of the content. The views expressed in this podcast by guests are not those of the host or the management. This podcast is not intended to impose any type of discrimination. My Fertility Podcast and its management are not responsible for any losses, damages, or liabilities that may arise from the use of this podcast.